Okay. So normal. Getting abnormal, very abnormal. So here it's at 2000 ohms. Pacing threshold is normal. The sensing is normal. So what has gone on here? Any thoughts? What does a high impedance mean? A lead fracture, yeah? Right? Well, yeah, absolutely. High impedance lead fracture. So, you know, if you watch football, threshold is normal. Threshold is entirely normal here. If you have a lead again, go back to the footballer. When they're playing football and they break their leg, they break their leg instantaneously. They don't break their leg at minute 2 in the football, and then the leg, you know, it doesn't last 90 minutes, the broken leg, right? It's broken immediately. This is a very gradually fracturing lead. This doesn't look like a fracture. Fractures look like this. They go normal, spike, normal, spike, normal, spike. Okay? And that's the start of the fracture. So the lead is fractured, but it's connecting up like a green stick fracture on a leg, right? So it's connected, unconnected, connected, and then you get the spikes when it's doing this, okay? When the cables are disattached from each other. Mineralization. Okay? Yeah. You're frowning. Never heard of it. This is something that you see with pacemaker leads and maybe defib leads sometimes, and it's a deposition of usually calcium and some other things at the electrode surface. So it's a very gradual biological process. Normally we see it in patients. If we see it in patients. Usually they're female. It's always females. They cause the problems. Yeah. No. It's usually females. And it's usually they have renal problems, but sometimes it's a male with no renal problems, and so it's odd, right? And we sometimes don't know why it's happening. But maybe I suppose lots of you do echo, yeah, and you do an echo on somebody and you see calcium deposits in the valves and wherever else. So it's like that. So you're not using that whole surface area. So the thing that reduces polarization, noise, is the huge surface area. But if there's air still sticking on the surface of the electrode, you're not using your whole surface area. So you create more noise. When that air dissolves off, then it turns into this. Almost always. Okay. So yeah, we would attempt to switch it on an implant if we could, because we think it gives you more safety margin. And you know. You may see it sometimes in the UK. Patients, we put a device in and then we set them up and then they go away and they never come back. They just disappear. And we don't know where they've gone. They've just gone. They never come back to the hospital. So we like to get our program of strategy right on day one on the table, because we're not sure whether they're going to come back or not. They might just disappear into follow-up, you know. So I'm not sure if that happens. Does that happen in Egypt? Patients get a pacemaker and run away? All the time. All the time, yeah. So that's the really important. That's why on the table, I think on the table programming is potentially vital for better outcomes. So we try to tune things up a little bit. Okay. So I'll cut through this and go to a quick just show you what it looks like here when it's doing it. So this I'll go to a case study. Go to case study, explains better.
I don't understand how the safety margin 5
Oh, okay, I'll show you. The safety margin is 5 volts or 4.5, depends on the device. So let me come back to this here. So back to this. So we're pacing here at say 1 volt, okay? Threshold is 0.75 and we are pacing at 1 volt. So this pulse here is 1 volt and it fails. This pulse, and the device goes failure, and then it brings in the backup pulse, and the backup pulse is either 4.5 or 5 volts, depending on the device. So this then is 5 volts. So that's why your backup, that's why your safety margin is 5 volts, right? Because if it fails, it paces at 5. And then it will run a threshold, work out that the threshold has gone up, and then add 0.25 on the threshold. So maybe this patient's threshold went to, was 0.75 here, but was 1.25 at this point here. So then, at this point, the device is pacing at 1.5 volts. Okay? And every 8 hours, it does a threshold. Every 8 hours, it just runs a threshold. And then it adjusts the output. So if the threshold came back down again, then it will bring it back down again. So you're saving some battery current, you're saving battery, making the longevity better, but more importantly, it's a safer setting for the device, for the patient, right? So because the patient cannot lose capture unless the lead comes out of the heart. Right? If the lead comes out of the heart and is in the SVC, then yeah, it's not that good. It's good, but it's not that good, right? Okay, does that make sense now? Okay, so this is a case study we had with a lovely patient, an 83-year-old man, and he had his pacemaker implanted 8 months earlier. Everything was stable, no symptoms. He had it for a complete AV block, no underlying ventricular rhythm, and then we brought him into clinic and we saw this. So this is a long-term trend. This is an older device, this is a case study from years ago. You can see it's 2006. This is when the device does a threshold, it logs it on a graph, okay? So you can see long-term trends of threshold. So what we see is this patient's threshold is really normal, really stable. Little bits of up, little bits of down, up and down, but not very much. All sort of around about 0.75. So this pacemaker was operating at a battery volt at an output of 1 volt most of the time, okay? And then, around about here, at this point here, this patient went to stay with his family. You can see it's around Christmas time. So he went to visit his family, and his family gave him food poisoning. So the poor man went to his family, they poisoned him, not deliberately, he just got food poisoning from the food. So he got food poisoning, and can you see what's happened to his pacing threshold? His pacing thresholds have gone, so he's lost lots of fluid, he's lost a ton of fluid, and his pacing thresholds have gone very high, okay? So his pacing thresholds have gone up to, and you can see here, pretty quickly, they've gone up to 2.5, 3 volts. Okay? So can you imagine, if you had a pacing threshold of 0.75, what would you program it to? 2? Probably 2 volts? Maybe 2.5 volts? You'd have lost capture. Okay? So, what does the device do? When it saw this, back up pace, ran a threshold. Started to increment the output, okay? Then he's over his diarrhea and vomiting, and then it all becomes normal again. So the device doesn't stay here. The device doesn't stay here. The device tracks it back down again.
How long was the device implanted?
8 months. So 8 months to this point here. So
Is there a possibility that with vomiting and this action that the lead would have microdisc after that time? No.
No, the lead hadn't moved at all, and then thresholds came normal again. This was his fluid levels were very, very low.
I have a question which I want to ask from the beginning of the lecture. You mentioned that the increase in threshold in the first presentation.
Yeah.
Is there a role of corticosteroids intake to decrease this threshold?
Yes.
And is there a role that this is one or two cases we saw before that if we give like amiodarone, the threshold comes up, and especially for LV leads.
Yes.
And then if we stop it and give some corticosteroids for a course, it goes.
Yeah.
Is this
So yes, steroids. These leads will have a steroid injection in them.
Yeah.
So behind the screw, behind the lead.
It's local. I'm talking about oral.
Yeah, no, absolutely. I've seen people do that. Particularly, I know some doctors. If your lead falls out, let's say that I'm sure your leads never fall out, right? But sometimes leads fall out. Some they do. Very rarely. Not Abbott leads though. Medtronic leads, no. So the lead falls out of the myocardium maybe 6 weeks after the implant or 3 months. So you go back in. And the lead's okay, right? So you use the same lead and put it in the muscle again, yeah?
Yes.
That's okay. What you've got to remember is that there's no more steroid on that lead.
Yes.
No more steroid.
Yes.
Okay? So you put it into the muscle, no steroids coming. Okay? So some doctors will give the patient, if it's okay, will give them some oral steroid, because what happens, when you put the lead in, you get inflammation at the lead tip, which pushes the lead back. Okay, so so the lead comes back, so it's further away from myocardium. Obviously not this far, but it comes back, and then as the swelling comes down, it moves back in again. If you have steroid, it does this, and then it comes back. If you have no steroid, it does this, and it only comes back a little bit. Okay, so some people, when you're doing that lead reposition, we'll give oral steroid. I think that's a really good idea because it makes your acute thresholds lower and it makes your long-term thresholds lower because the lead will come back into that position. I mean, some patients obviously are not good for oral steroids, right? But yeah.
But we are talking about regular patients,
Yeah.
no contraindication.
Yeah. I think when you're repositioning the lead, I think that's a certain something to think about.
Steroids will decrease the edema, the local edema,
Yes,
so
absolutely.
the lead will not move back.
Yes, absolutely. Yeah, absolutely. And that's something that sometimes that people don't consider when they're doing a lead reposition, to think about giving some steroids, okay? Because you put the lead in, it works, but in the next 6 weeks the threshold is going to go up. It will go up, okay? Steroids will keep it low long term, okay? So that's the benefit of having steroids. So yeah, so this patient was not aware that he had any threshold rise. He was aware that he had diarrhea and vomiting, obviously, but he was not aware of his threshold rises. So this is where this is where his gastroenteritis, got some hospitalisation, got some IV fluids on board, discharged and was fine. Okay.
So this case demonstrates the importance of programming auto-capture right at the beginning, from the start, from implantation.
Absolutely.
To keep your patient safe.
Yeah, absolutely. So this, absolutely.
This is the idea.
Yeah. This is we would recommend auto-capture on at implant because if this patient, we can see what would happen. This patient would not be in a very good way, right? He'd be in hospital for more than gastroenteritis, right? So we like to do that at implant, and other companies have algorithms like this. Some are beat to beat, some are not beat to beat. Okay, the Abbott one is beat to beat. So if it loses, it brings him back up. Okay, and it gives you these lovely trends. Okay.
You mean beat to beat? It monitors the threshold beat to beat.
Yeah.
But it runs the test every 8 hours.
Every 8 hours it runs the
Threshold
test.
Okay.
Yeah, so when it paces, every time it delivers a stimulus to the ventricle, it checks. So pace, check, and if it doesn't capture a backup pulse, immediately.
That's why you program your pulse amplitude just 0.25 volts above the
Correct, the pulse,
threshold.
absolutely. Yeah, that's automatic within the function. We don't program that. That's just part of the algorithm.
Yes.
That's just part of the
Part of
algorithm.
the
So 0.25 above the measured threshold that the device measures. Okay.
Because other companies, they don't do that.
No.
They don't.
No, we do. So auto-capture's been around for 15 years. And we've developed it over 15 years, and it works really well. It's one of the key functions, I think, in our pacemakers. We also have it on our dual chamber ICDs and our single chamber ICDs. It's less important on those patients because they tend to have intrinsic conduction. But yeah, it's So it's probably one of our key functions. Okay, happy? So, quick. This is to do with capture. Not to do with auto capture. Don't forget about auto capture. Keep remembering auto capture. It's good, right? But this is just a quick example of something that we see. This is a CRT device. I know CRT is later on today, but this is to do with capture. So let me just show you what's happening here. This is the atrial lead. So we're ignoring the atrial lead. Forget about the atrial lead because the atrial lead is fluttering. Okay, so we're done with that. This lead is the RV lead. Okay, this is the RV signal. This is the LV channel. And we are pacing, this is pacing the left ventricle. So this is left ventricular pacing at 7.5 volts, 7.5 volts, 2 volts, 2 volts, 2 volts, 2 volts, okay? So, question is, do we capture the left ventricle? So this is the left ventricular electrode, this is the RV electrode. Are we capturing the left ventricle? It's not a trick. Yeah. It's capturing left ventricle. When we pace, we have a resulting depolarization on the left ventricular lead. Look, pace, always, pace, always, pace, always, pace, always. Okay? So we capture. Good. What's happening on the RV lead? LV. This is the atrial lead sensing. Okay? So pace LV. This is the RV signal. Okay? So pacing LV, And at the same time as I capture the left ventricle, the right ventricle captures. I'm only pacing the left ventricle, but I pace the left ventricle and the right ventricle captures. Okay? Here, I pace the left ventricle, the right ventricle doesn't capture. There is a delay to seeing the wavefront coming past the RV lead. Okay? So this here is a phenomena known as anodal capture. Anyone heard of anodal capture? You will see that in CRT devices, okay? So we're pacing the left ventricle is the cathode, and we're using the RV ring as the return pathway, okay? If you make the voltages high, you can capture on the LV, and you can capture on the ring electrode of the RV, okay? So this is a phenomenon known as anodal capture. So the cathode captures and the anode captures, okay? So this is basically biventricular pacing. Here. Here, we capture the LV, but we don't capture the RV, and this is the conduction time from LV pace to the RV electrode, the electrical conduction coming from LV, going past the RV. And this is what you want to be seeing when you're doing LV thresholds, okay? You don't want to be seeing this, okay? You don't want to be seeing this, because if you have this, and you program a VV offset, so you say pace the LV 40 milliseconds before the RV. If you have this, it doesn't happen. You get just simultaneous LV pacing, okay? And you can get, this can be very strange, okay? Sometimes you cannot capture the LV. So you pace in the left ventricle, it doesn't capture at the left ventricle, but it captures the right ventricle. So you're pacing LV, but you're capturing RV. And it's just capturing at the ring electrode, the return pathway. It normally happens when you put the outputs up to sort of 3 volts, and then it can potentially capture the ring electrode, okay? And it's really important to be able to detect that, especially in older devices, where they use the ring electrode a lot, because what you can do is you pace LV, and you see an ECG happen, yeah? You see capture. But it's capturing the right ventricle, and this is in a CRT patient. So you're not capturing LV, you're only capturing RV. You're going to make them sick. Yeah. You're going to increase their mortality, and you're going to cause decrease in their morbidity as well. Okay. So how many people do ECGs when they do CRT? Yeah, 12 lead ECGs. Anyone? Yeah. 12 leads. Oh, that's perfect. So I was at a talking an European Heart Rhythm Association meeting last week in Vienna, and Christophe Leclerc, who is the president-elect of ERA, said it is mandatory that we have 12 lead ECGs when we put CRTs in. So at the implant, it is mandatory. He said, and also he said it's mandatory that we do 12 lead ECGs at CRT follow-ups. Okay. So we should, and if you do the 12 lead ECG, you will see this, because this here, or you will see if you're just capturing on the RV, because you'll have a left bundle pattern, right? Okay. We'll look at some CRT ECGs later.
So usually you have this problem. If you have high pressure from the beginning from the
Yep.
LV and you programmed your amplitude very high, so you're faced with this problem.
Yes.
And if you program the polarity.
Yes, if you program the polarity to the RV ring.
Yeah,
So
this
it'll
is
only happen
disastrous.
if you use the return pathway as the RV ring. That's the only time it will happen. If it's LV1 to LV4, it's fine. If it's LV to RV ring, avoid the ring. Keep off the ring, it's bad. I've seen patients who've come to box change with CRT devices who are programmed LV, these are bipolar devices, LV tip to RV ring, and for 5 years they have not captured their left ventricle. They've been capturing their right ventricle, and they are a non-responder to CRT therapy. In fact, we made them worse.
Yeah.
In fact, we made them a hypo-responder.
Okay.
We hurt that patient.
So this is a point of caution that don't ever program your polarity in the LV tip to RV ring.
ring. Yeah.
Don't ever do
We
this.
call it cathodal stimulation.
Anode.
Anodal?
Anodal capture.
Anodal
Anodal capture. Yeah, capture at the anode. Yeah. It's common. You can make this happen on almost any patient. If you go to the anode, if you use the anode as the RV ring from the LV, so stay away from the ring electrode. Go LV1 to LV2 or LV to coil. If it's a defib, go into the coils. Okay. It can happen on the coil, but it's extraordinarily rare. I've only seen it once, and I've been doing this for like 24 years. I've seen it like once or twice. Okay? So, yeah. Okay? So this is what anodal, what you've actually got here is anodal and cathodal capture. Okay? Yeah? The pattern would change. If you had just anodal capture, the pattern would change. And what you would see is you'd see RV capture, and then the LV would be here. Yeah? Because the wavefront's moving from the RV coming across to the left ventricular electrode, okay? You'd have a reverse of this here, okay? Yeah? So you can look at it, you can see it on intracardiac electrograms and pick it up, it's easy, but also you can see it on ECGs. And Christoph says it's mandatory, so, you know, I know we're not in Europe here, but, you know, Christoph kind of knows what he's talking about, I think. Anyway, okay, so that's a little bit about some of the pacing impedance things. Okay, everyone happy so far? Good. So sensing physics. So let's look at some sensing stuff. So number of things that we need to consider or going on in these devices. So important things to consider. We have a bandpass filter, the signal amplitude and the slew, the sensitivity setting, and something called differential sensing, which I'll come on to in a minute. Which you can. This explains a lot of things in sensing. This last bit here. So the bandpass filter is built into the pacemaker, and it is a mechanism of filtering out stuff that we don't want to see. Okay. So if you look at the raw signal from a pacemaker lead, so I just give you the raw signal and didn't put it through this here, but through the bandpass filter, it would look like noise, just loads of noise. And it would be loads of very high frequency noise, and it would be going up and down like this here. And you would say, well, what do I do with that? Okay, so the bandpass filter filters out respiratory swing. So this side of the filter filters out sort of, if you like, slow moving things. So it filters those out. And this side of the bandpass filter filters out very high frequency stuff like myopotentials, skeletal myopotentials. Okay, so we have. So what we do, things outside this curve here. So this is very high frequency here, and this is higher amplitude. We flatten those signals so we don't see them. Okay, we don't get rid of them. We flatten them so we don't see them. And here, this is low frequency. This is low frequency and low amplitude. It's like respiratory swing, T waves, things like this. Okay. The idea of the bandpass filter is that we amplify things that we want to see. So cardiac signals, we boost them, we pick them out, and we make them bigger. Right. The sense amplifier, the bandpass filter, makes these signals bigger. Okay. Otherwise, it's just noise. Okay. So when you're putting in an Abbott pacemaker. So if you're implanting an Abbott pacemaker, which pacing system analyzer do you use? You can be honest. Which PSA do you use? Do you use a Medtronic one?
Use either or according to the implanting device. Yeah.
Okay, so you use ours. Okay.
Yes.
Yeah.
Sometimes yours and sometimes Medtronic. Yes, and sometimes Boston. Yes, I'm kidding you, shooting you.
So the important, it's okay, you can do that, it's okay. As long as you put the Abbott device in, it's okay.
Actually, what Century do, they keep the module in their pocket, so that if I implant from another company, I don't have a advisor.
Ah, I see, they should put it here. So you can get it out of the pockets, take it out of his pocket. So so why did I mention that? I mention that because if you use a Medtronic PSA and then you're implanting a St. Jude device, the bandpass filter on Medtronic devices is different, okay? So their PSA bandpass, their PSA operates like, has a bandpass filter that's like their pacemakers. Okay? Our PSA operates like the bandpass filter in Abbott pacemakers. So you will get slightly different signal amplitudes, okay? Typically, if you could try this next time. Usually, if you measure the signal on a Medtronic device, on a Medtronic PSA, it will be smaller than our signals. Okay, so you'll do Medtronic, maybe you get 6. Abbott, you might get 8. Okay, but can you imagine if it's 4, right? So if it's 4 on a Medtronic PSA, you might move the lead, right? It might be 6. So we would recommend you use our PSA filter on the pacemaker that you're going to put in. Okay.
We always see change in the sensitivity after implanting the pacemaker and interrogating the pacemaker by the one.
Yeah.
It's always different.
If you use this, you should see very, very little difference.
Yeah.
Very little difference, like less than 1 millivolt. It's the same filter.
In some hospitals, when we don't have enough time to inform the company about the implantation procedure, we use the temporary external
Okay.
pacemaker,
Yeah.
but this gives us an indirect information. Like
Completely.
we program the make sensitive, like our wave 2, sensing 4. This is indirect.
Sure.
It doesn't exactly measure, and sometimes the connecting cables are locally made from normal wires, electrical wires like used in the kitchen, and this is how they transmit the signal. So sometimes I tell them, don't trust what we see now, because this is some values are not measured in the wiring in the system, but that sometimes you are obliged to use this machine in order to have crude measurements of the signals. The problem is with the atrial signal because it's very little, so and the accuracy is not that correct.
Yeah. And that's, those difference in sizes of using a temporary box is because the bandpass filter is completely different to what we're doing on the device. Okay, so that's why I talked about that. So it's good. We like to use our PSA rather than someone else's PSA because it's a better reflection. Okay, and it could potentially save you from moving a lead at an implant, right? That's the potential. So that's the bandpass filter. So signal amplitude and slew rate. Does anybody measure slew rate anymore? Some people.
I saw it in Europe.
Saw it in Europe, yeah. Well, some people measure.
Does it have any meaning?
Yeah, it does. Yeah.
What is the meaning?
So the slew rate is how quickly the signal moves.
Yeah.
So it's a change in voltage over time, right? So if I go back to the bandpass filter, if you have a bad slew rate, okay, that means it's over here, right? So this is low frequency, okay? So a low slew, okay, not a sharp signal, a gradual signal, is over here. And if you have a bad slew and a small signal, so this is so small, low slew, you're here. And then the bandpass filter will flatten the signal, okay? So the signal will be smaller than so slew rate is important, and slew rate will get reported on your device. So typically we're looking at kind of signals like this here. So these are your kind of acute kind of signals on here. So most people don't move it. So you want a sharp signal, okay? Normally more than a volt per second. That's typically what you want to be seeing. Okay, sensing threshold, I'm sure you all know about that. So sensing threshold we have, so normally we'd set the sensing threshold around about 2.5 volts or 2 volts for the pacemaker, for the right ventricular lead. For the atrial lead it's more difficult, right? Because the P wave might be this big, but the P wave in AF might be a lot smaller, okay? And you want to pick this up because you want to know if your patient's having AF, so he might be at risk of stroke, right?
Yes. So
we need to pick this up here. So there are some challenges with sensing, okay? Remember, AF in pacemaker patients is, if they're the right age and the right sex and things, they might have high risk of stroke, okay? So we like to pick AF up early and anticoagulate if necessary, or send them for EP and whatever else. So what we normally have, move through this here quickly, is normally for the RV lead, we have a fixed sensitivity, okay? So this is a ventricular lead, and normally it's fine, because in pacemakers the signal is the same, the R wave is the same, no problem. We set it at 2.5. This is an atrial signal, okay? So this is not an RV signal, this is the atrial signal in AF. And what you see is you have very changing cycles, amplitudes, okay? So you can miss things. And all of these could be below the max sensitivity. So typically we set the sensitivity on the atrium of maybe 0.75 of a millivolt to 1 millivolt, but they can be smaller than that, so we would undersense AF. So what we try to do today is instead of, I'll move through all these setups, what we try to do today is use a slightly different sensing function, which is not fixed, okay? So it responds to changing cycles, changing R waves, and it's, this is not the ideal slide, but let's look at a signal like this here. So when you use fixed sensitivity, you just have a number and it runs like this. Okay, this might be on a pacemaker and an atrial lead 1 millivolt. Okay, we may get signals down here that are smaller. We have automatic sensitivity function, which looks at the size of this signal. So it measures the size of this signal, and it starts usually about 50% of the size of the signal. So the sensitivity starts here, but instead of going like this, it does this. It declines, okay? So if you are changing signal amplitudes, this decline in sensitivity will pick them up. So then if the signal is this big, 50% of this, it gets more sensitive. So on our atrial leads, we often like to use automatic sensitivity because it provides better detection for AF. Okay, much better detection for AF. In our ICDs and our CRT-Ds, all channels, the atrial channel and the ventricular channel, are automatic sensitivity because we're trying to detect VF, right? So VF goes from big signal and in sinus rhythm to very, very small signals, and we need to track those down because typically they will often be, after about 30 seconds, 20 seconds, those signals in VF will be less than 2.5 millivolts. So we need to get to very high sensitivity with our defibrillators.
The engineers and technicians of Abbott,
Yeah.
the cable is atrial port and ventricular port. And they make us measure everything with one port, like ventricular port. Is that okay?
I would put it in the right port. If I was measuring the atrium, I'll measure the atrium. If I'm measuring the ventricle, I'll measure the ventricle.
Sure.
It's, we'll make that change.
Okay. So it makes a difference, right?
It can make a difference, yeah. Particularly if
They go down with the sensitivity.
yeah, they go around sensitivity,
They,
but it is using slightly different band passes on the atrial leads, yeah.
Okay.
Yeah, it will be using a different band pass. It usually doesn't make a lot of difference, to be fair. The difference is not much. You often don't see much difference, but there is a potential, small potential.
So with this new sensitivity decaying, is there a problem with oversensing? Would be a
Sometimes.
problem with oversensing?
Sometimes. And we'll see some oversensing tomorrow, because we're doing defibs tomorrow.
Okay.
If you're declining the sensitivity, let me just grab something
You're
here.
not going that way, you're just going that way, so you will have
This is heavy.